Today's topic is infection prevention and control for the laboratory. I'm going to speak about IPC practices in general, and then we're going to talk about IPC more specific for the laboratory. So we're going to start with standard precautions, and then we're going to talk about laboratory infection control practices. So at the end of the session, hopefully you should recognize the application of standard precautions, infection control principles as applied to laboratory procedures, including laboratory design, laboratory safety equipment, techniques that prevent the transmission of infection. I'm going to talk briefly about disinfection and sterilization in general and in the context of the clinical laboratory. And then we're gonna finish off with immunization of laboratory workers. So protecting the health of health facility staff and preventing transmission of infections from patient to staff, from staff to patient, from patient to patient, from patient to visitor, and from staff to staff is a primary responsibility of all healthcare facilities. And in order to accomplish this, healthcare facilities implement what's called a hierarchy of controls. And this slide depicts the controls from those that are most effective to those that are least effective. And the idea behind this hierarchy is that the control methods that are at the top of the graphic are potentially more effective and more protective than those at the bottom. And following this hierarchy of controls normally leads to implementation of inherently safer systems where the risk of illness or injury has been substantially reduced. In looking at the individual components of this, elimination and substitution are the most effective at reducing hazards, but they also tend to be more difficult to implement when existing processes are already in place. Engineering controls involve isolating individuals from the hazard, and engineering controls are favored over administrative controls and PPEs or personal protective equipment because they're designed to remove the hazard at the source before it comes in contact with the worker. Well-designed engineering controls can be highly effective in protecting workers and will typically be independent of worker interactions to provide that level of protection. Administrative controls, that is rethinking the way the work is done, and PPEs are frequently used with existing processes where hazards are not particularly well controlled. And while administrative controls and PPE programs may be relatively inexpensive to establish, the problem is that they require significantly more effort by or rely on the affected or exposed workers. So they tend to be more costly to sustain and much less effective. Excuse me. So I'm going to talk first about standard precautions. So standard precautions were conceived in the mid-1980s, initially in response to HIV/AIDS epidemic, because unsuspected infectious agents were found to be present in blood and other body fluids. And so these measures apply to all patients, regardless of the diagnosis or whether or not they're known to have an infection or be colonized by microbiological agents. The purpose is to reduce the transmission of pathogenic microorganisms by preventing exposure to blood and other potentially infectious body fluids. The standard precautions include a risk assessment, which is done every time you come in contact with a patient, hand hygiene, the use of personal protective equipment, respiratory hygiene, and standard precautions were expanded to include this component, the respiratory hygiene component, in response to the experience with SARS outbreaks in 2002, so in 2003. So this is a relatively new addition to standard or universal precautions. Safe injection practices and prevention of exposure due to sharp accidents with sharp instruments, and care in managing the environment. So this incorporates environmental cleaning and waste management and handling of textiles and laundry. And the next component is sterilization and disinfection of medical devices and medical equipment, and that would include devices and components and materials that are used in the laboratory. And then it's important to note, though, that the effectiveness of standard precautions depends on how well the steps are followed, and they always, as I stated at the beginning, always have to be preceded by a situational risk assessment, which we're going to discuss a little bit more in the second part of the talk. So we're going to talk first about hand hygiene. So conducting hand hygiene at the right time, using the right technique with either an alcohol-based hand rub or soap and water and disposable clean towels is critical. So first and foremost in standard precautions is hand hygiene. There are two types, as you would be aware, there are two types of microbial flora that can be found on hands, those that reside there and those that are transitory. And so both participate in the transmission of healthcare-associated infections when the hands of health personnel touch patients or objects of their environment. Hand hygiene reduces the number of microorganisms that are present on the hands. Mainly, it removes the transitory flora, and it is one of the most effective strategies for preventing cross-transmission of microorganisms that cause healthcare-associated infections, or HAIs. Hand hygiene is the act of either washing one's hands with either soap and water or through the application of an antiseptic hand rub, most commonly employed being an alcohol-based hand rub, to prevent the transmission of microorganisms from one person to another via contaminated hands. The method employed in ensuring that hand hygiene is effective falls into one of two categories, as depicted here. Hand rubbing with an alcohol-based hand rub is the gold standard to perform hand hygiene on all occasions, except for those described for hand washing with soap and water. That is, hand rubbing is the action recommended for healthcare workers for routine day-to-day decontamination of hands. Hand washing with soap and water still occupies a central place in hand hygiene and should be employed when hands are visibly dirty or visibly soiled with blood or other body fluids after using the toilet, and when exposure to potential spore-forming pathogens is strongly suspected or proven, including during outbreaks of diarrhea. The following behaviors should be avoided with respect to hand hygiene: using soap and water and alcohol-based hand products simultaneously, using hot water for washing hands with soap and water, donning gloves when your hands are wet, as this can cause irritation, and performing hand hygiene outside the framework of indications, and wearing gloves outside of the indications of the framework of indications. And what I would like to stress at this point is gloves are not a substitute for proper hand hygiene. They are an adjuvant to the hand hygiene process. So no matter what you do, gloves or not, hand washing or hand hygiene with an alcohol-based hand rub are critical and do not ever get substituted by the use of gloves. So it's not either or there. If you're going to wear gloves, it would be in addition to the application of appropriate hand hygiene. So how do you hand rub? And in this instance, I'd like to point out to you that steps 2 to step 7 are the same, whether you are applying an alcohol-based hand rinse or you have applied soap to wet hands and you are performing hand wash. So the first thing you do is you rub palm to palm, and then you do the backs of the hands. Then you do inside the fingers. You cup your fingers and scrub them inside each other, twisting back and forth. You clean the thumbs, You clean the tips of the fingers, and this is something that a lot of people always forget. And then when the hand rub is dry, then your hand hygiene process has been completed. And as you can see in the next slide, for how to hand wash, steps 2 to step 7 are all still the same. What's important to note is here, they say you should first wet your hands with water before you apply the soap. And the reason for this is that it decreases irritation, and so your hands will not become as chapped from hand washing if you apply soap to wet hands. And then at the end, you rinse your hands, dry your hands, and then use the tissue or the towel to turn the water off. And at that point, you should have clean hands. So as I noted in an earlier slide, respiratory hygiene was added in 2003 in response to the SARS outbreak. And this element of standard precaution protects against diseases that are transmitted via the respiratory route, including diseases such as influenza and COVID. So based on the available evidence, the COVID-19 virus, as we know, is transmitted between people through close contact and droplets, not by airborne isolation, or not by airborne transmission. And the people most at risk of infection are those who are in close contact with a COVID-19 patient or who care for COVID-19 patients. But the same principles apply for diseases that are transmitted by the droplet route, including diseases such as influenza, which we see annually. So prevention and mitigation measures are key in both healthcare and community settings. And so persons with respiratory symptoms, how does respiratory hygiene or cough etiquette work? Persons with respiratory symptoms should apply source control measures. That is, they should cover their nose and mouth when coughing or sneezing with a tissue or mask, or in the crook of their arm, not in the palm of their hand, and then dispose of the used tissues and masks and perform hand hygiene after contact with their respiratory secretions. If they do that every time they cough or sneeze and perform hand hygiene after appropriately disposing of the tissue, they can in fact decrease the risk of transmission to those persons around them. So in healthcare facilities, and this would apply in laboratories as well, in healthcare facilities, they should place acute febrile respiratory symptomatic patients at least 1 meter away from others in common waiting areas if possible. During respiratory season, it's important to post visual alerts at the entrance to healthcare facilities, instructing persons with those respiratory symptoms to practice respiratory hygiene and cough etiquette. Healthcare facilities should consider making hand hygiene resources, tissues, and masks available in common areas and areas that are used for the evaluation of patients with respiratory illnesses. And it's important to note that these principles apply to healthcare workers as well as patients. So this remains applicable in the laboratory setting as well. So persons who present to work with signs and symptoms of upper respiratory illnesses should practice respiratory hygiene or cough etiquette in order to prevent transmission to their coworkers. The next component of standard precautions is safe injection practices and prevention of exposure due to accidents with sharp instruments. And according to the WHO Best Injection Practices Guideline, a safe injection does not harm the recipient, does not expose the provider to any avoidable risk, and does not result in any waste that is dangerous for other people, including those in the community. So, although most clinical laboratories don't prepare medications for injection, they frequently are responsible for collecting blood specimens through phlebotomy. And many of the same principles are applicable to phlebotomy, but also to the reconstitution of diluents and other solutions that are used in the laboratory setting. Excuse me. So, what are the components of safe injection practices? Use a new sterile syringe and needle from undamaged, unopened packaging. You want to prevent contamination of vials that are being accessed or reconstituted. And you do this by wiping the access diaphragm or the septum with 70% alcohol, either isopropyl or ethanol, from an alcohol swab, a pre-packed, individually packaged alcohol swab, or from a newly moistened cotton wool ball before piercing the vial and allowed to air dry. Now, you should do this every time you have to access any vials. And the reason for that is that you never leave a needle in the top of an opened vial, because the interior, the contents of the vial can become contaminated. But you also want to make sure that a lot of people will pop the protective cover off of it and then think that the interior is already sterile, and it's not. So you need to make sure that you always wipe the septum before you access the vial. You want to pierce the septum with a sterile needle every time it's used. When possible, you should select pop open ampules. And if you're using an ampule that requires a metal file to open, it's important that you use a small gauze pad to protect your fingers while opening it, to prevent injuries to your finger. Whenever possible, it is recommended that single dose vials are used. And if you have to use multi-dose vials, especially with diluents and such, you must take care to avoid contamination of the contents. And as I stated, you never leave a needle in the stopper of the vial, because that will guarantee that the interior contents will become contaminated. It's important to prevent contamination of injection equipment and medication. So you always follow product-specific recommendations for use, storage, and handling. In the event that injections are being prepared, you want to prepare that injection in a clean, designated area, away from heavy traffic flow, and also away from areas where people are eating and drinking. It's important to remember that any of the vials that appear contaminated, either cracked, the integrity is not there, it's cracked, it looks like it's been leaking, then those vials should be discarded. And you should never use a needle or a syringe if the package from which you take it has been punctured, torn, or it appears to have gotten wet. Gloves aren't needed for most injections, although the caveat is that over time, the practice of wearing gloves for phlebotomy has become a standard of care, a standard practice. But for experienced phlebotomists who don't anticipate coming in contact with blood from the tubes or the vacutainer, don't necessarily have to wear gloves. But it depends on the level of experience of the practitioner as to whether or not they wear gloves. But if gloves are worn, single-use gloves should be used. Wash or disinfect the hands before donning the gloves. Make sure your hands are dry. Put your gloves on. Disinfect the skin. So again, using 60 to 70% alcohol-based solutions, either a single-use swab or an immediately moistened cotton wool ball. You should never see cotton wool balls in jars or in cups of alcohol. What happens is that with hands going in and out, the alcohol loses its potency and the cotton wool balls actually become contaminated. And so it is possible that you can cause infections in people if you don't use a freshly soaked cotton wool ball. You want to prevent access to used needles. So whether you're using needles for some reason in the lab, or you're out on the floor conducting phlebotomy or or collecting specimens, other specimens that might require needles, needles and syringes, then it's really important that that they are placed in sharps container. You want to manage sharps in a safe, efficient way. So you want to protect people from exposure to used injection equipment. You want to prevent needle stick injuries. So it's important that if you are participating in phlebotomy practices and you don't know the patient, or there's a risk that the patient is going to jerk or move, then you should have someone assist you, because what can happen is that if a patient has a sudden movement during that phlebotomy practice or during that specimen collection, and you're using a needle and syringe, then it is possible that you as a healthcare worker can become accidentally injured with the needle. You should always avoid recapping or any other type of manipulation of the needle. And if you have to recap, then you have to use a single-handed scoop technique, making sure that the bevel of the needle is fully covered before you use your hand to secure the needle cap on the base of the needle. Discard used syringes as a single unit in the sharps container immediately after use, which implies that you should have a sharps container at your hands, right at the bedside with you if you are doing phlebotomy. So you want to make sure that you don't have to carry the needle somewhere to dispose of it. And then collect used syringes and needles at the point of use, and those should be puncture and leak proof, and they should be sealed. Those containers should be sealed when they're 3/4 full, to avoid needles from popping back out and causing sharps injuries. The next component of standard precautions is cleaning, disinfection, and sterilization. And cleaning is the first step that's required to physically remove contamination by foreign material. It can be dust, it can be soil, it can also be organic materials such as blood, secretions, excretions, or microorganisms. And the physical cleaning process is a preparatory step for disinfection or sterilization. So cleaning removes the dirt that's deposited on inanimate surfaces in one of 3 different ways: either mechanically, which is friction, physically, which is by temperature, or chemically by means, or chemical means for a certain length of time. Disinfection, on the other hand, is a physical or chemical process in which vegetative microorganisms are removed from inanimate objects, but without the assurance that bacterial spores have been removed. So in this component, we're talking about disinfection as the use of chemical agents. They come in intermediate level disinfectants such as phenols and sodium hypochlorite or bleach that remove vegetative bacteria and some bacterial spores, as well as the use of chemical agents known as low-level disinfectants. And those are typically quaternary ammonium compounds that remove vegetative bacteria and viruses. Low-level disinfection is generally used for environmental cleaning, and intermediate level and high-level disinfection is used for items that are used in the healthcare setting. High-level disinfection is indicated for semi-critical articles. Those are instruments or materials that come in contact with the mucous membrane of the respiratory, genital, and urinary tracts, and when skin is not intact. And although mucous membranes are usually resistant to infections by bacterial spores, they can present infection when they are contaminated with other microbial forms. So for this reason, they should be sterile, or at the very least submitted to high-level disinfection. This includes, for example, respiratory assistance devices, anesthesia, and endoscopic devices. Intermediate and low-level disinfection is indicated for non-critical articles, and those are instruments or materials that only come in contact with intact skin. In this instance, healthy skin acts as an effective barrier that keeps out the majority of those microorganisms, which is why they don't have to have high-level disinfection. And in general, only adequate cleaning and drying are required with the need for immediate, intermediate, or low-level disinfections. So the types of things that you would use for intermediate or low-level would include things like mattresses and furniture, incubators, blood pressure cuffs, so things like that that generally come in contact with intact skin. And then sterilization is the strictest of all of the components, and this is sterilization is a validated process, and it's used to render an object free from viable microorganisms, including viruses and bacterial spores. And critical articles that require sterilization are instruments that come in contact with cavities or including the vascular system. And these articles pose a high risk of infection if they're contaminated with microorganisms. So this would be items such as surgical instruments, cardiac probes, catheters, and prostheses. So when we speak of care of the environment, we're talking about, we talk traditionally about the environment of care, that is the patient's areas, but these principles also apply to the laboratory, at least as far as routine cleaning goes. So we are going to talk about it with that component in mind. And when we talk about linens here, it doesn't necessarily mean bed linens, but it could be other healthcare associated textiles. So this could include lab coats. This could include towels that might be used, in cotton towels that might be used in the laboratory, or other components like that. So it's important that the persons who clean in the laboratory have been educated, and we're going to talk about that in the risk assessments. But it's really important that they're properly trained, that they are familiar with the supplies that they're going to use, and that they understand the processes and the order in which these processes need to be applied in order to effectively clean the area, decrease microbial bioloads, and also to protect themselves from becoming self-inoculated and infected. So when you talk about routine cleaning and the process that it goes through, some surfaces are considered frequently contaminated given their functions. So these types of articles need to be cleaned more frequently than those that are less frequently contaminated or less frequently touched. So things like sinks, latrines, faucet handles, bathroom countertops. In the lab, attention should be paid to additional frequently touched surfaces. So we're talking about not only the bench tops, but then also areas such as the cabinet poles, the operating keypads on the equipment and machines, and things like that. So those components in the laboratory setting, in the work area setting, which are frequently touched, should be cleaned more frequently. So at a minimum, the laboratory should be cleaned at least once a day, but more often if visible contamination is seen. So routine cleaning occurs, usually routine cleaning in the floors in the patient wards occurs when a patient occupies a better room, and terminal cleaning occurs when the patient's discharged or transferred out of the better room. So the laboratory work area should be cleaned daily, as I said, and more frequently in areas that are prone to heavy microbial contamination. So, and that's part of a risk assessment that should be done by the laboratory supervisor or the laboratory director, and it should be incorporated into the cleaning process of the laboratories. So when you talk about cleaning in the patient space, and this process, this routine cleaning process here, actually applies in all areas. So the first thing is that you want to visually Before you go into the area, you want to visually assess the area that needs to be cleaned. You're looking for supplies that need to be replaced, or any items that may be broken that need to be removed. The environmental cleaners should collect their supplies. It's important to make sure that they have clean cloths available for cleaning. Their cleaning solutions, their detergents, should be diluted correctly. And if they are using disinfectants to disinfect the areas after they have cleaned the areas, it's important that those are also diluted correctly. And then, so as part of the first steps, they would restock those missing or low stock supplies. The person performing the environmental cleaning should perform hand hygiene and put on gloves. And then they should clean, working from clean to dirty areas, as well as from high above to lower down. So the last area that should be cleaned in any area should be the floor. So that should be the last process that takes place. It's important that they clean the furnishings in the area as well. So they should be wiping down the chairs, the tables, any of the desks that you have. I know typically in the laboratory that the techs clean the bench tops, so then that's fine. But for the other areas in the daily cleaning, the chairs that people are sitting on and things like that should also be cleaned by the environmental cleaner. The light switches, the door handles, the doorknobs, all those types of things. They should concentrate on those that are frequently touched, like I just talked about. And then even in the laboratory, unless there is a spill, there is no need to use a disinfectant on the floor. The floor just needs to have a detergent to remove the dirt and grime that can trap microorganisms. So if they are using reusable cloths for cleaning, for wiping down door handles and chairs and desktops and all that type of those types of equipment, then those cloths should be put in a container to be laundered. So that would be part of the linen management of the textiles that are used in the hospital. Those cloths should be cleaned in hot water and hot air dried. And the reason for that is because it decreases microbial load. When you talk about using mops, and this mop is very reminiscent of the cotton cloth mops that are used. Cotton cloth mops should not be used in healthcare setting. And the reason for that is the mop head should be removable so that it can be washed in hot water and hot air dried to decrease the bioload. This is particularly important in laboratory areas where there is a preponderance of potentially infectious materials, and you could have unrecognized droplets, splatters, and splashes. So you want to make sure that the mop that's being used in there has a removable head that is sent to the laundry for appropriate washing. And then as far as waste disposal goes, then it's important to note that for the waste, it should be placed in appropriate containers. So general waste should be in a regular bin. Infectious waste should be placed in the appropriate, like color-coded or labeled bin for terminal decontamination and or incineration. And then as the person finishes their cleaning in that room, they should leave in that work area, they should remove their gloves and perform hand hygiene. So those are the basic steps for care of the environment as far as standard precautions goes. So I talked briefly about waste disposal and linens. So it's really important that there is safe waste management, particularly in the laboratory setting. So you want to treat waste contaminated with blood, body fluids, secretions, and excretions as clinical waste. Human tissues and laboratory waste that is directly associated with specimen processing should be treated as clinical waste. It's important that single-use items are disposed of properly and not reused. And then red bag waste or clinical waste, which can transmit infectious diseases and can also be referred to as pathological waste. Generally, you identify that as a lot of the materials that you're familiar with. So that would be your laboratory materials, your cultures, your bloods, and any derivatives, any pathological anatomy material, and material that the laboratory receives from operating theaters, sharp pointed elements, all devices that have sharp rigid corners, edges, or protuberances capable of cutting, and that would include needles, scalpels, and broken glass. And then waste with blood and or body fluids and everything that is used with the patient. When you talk about waste that is contaminated with blood, they're not talking about a drop of blood. They're talking about a volume of blood that is capable of transmitting diseases. Because remember now, it's all about your infectious dose and how much do you have to be exposed to. So if it's a Band-Aid with a drop of blood on it, that wouldn't necessarily have to be managed as infectious waste or red bag waste. But a dressing or a specimen that you receive that is dripping with blood would obviously be handled in a very different manner. General household waste doesn't require any special treatment. So this includes things like paper, boxes, cardboard, packaging, and every disposable element that doesn't contain blood or biological liquids, including administrative waste. Excuse me. In the laboratory, you also have to be concerned with chemical waste. And this includes chemical products and anti-neoplastic drugs, although you wouldn't be managing anti-neoplastic drugs. And those have to be disposed of according to however your ministries of health or ministries of the environment have set that up. So for linens, the process that's used for managing your linens, it's really important that you prevent skin and mucous membrane exposure and contamination of clothing. So in other words, you don't want to once you've removed the lab coat or other textiles that are used in the laboratory, you want to make sure that those don't come in contact with your personal clothes. And you don't want them to come in contact with like the skin on your forearms and all of that. So when you remove your lab coat, it should be rolled up carefully and then placed in the appropriate linen management bag system. And you want to avoid transfer of pathogens to other persons in your area. So careful handling to prevent that type of transmission is going to be very important. The use of personal protective equipment. So this next section deals with, I'm going to talk about the appropriate use of PPE. The use of PPE is designed to protect you as health workers from exposure to microorganisms, but it's also important to remember that you have to provide a safe environment for your peers as well. And so it's going to be really important. According to PAHO, personal protective equipment is intended to form a barrier that prevents contact between health workers and an object or environment in order to prevent the transmission of infectious agents. Appropriate PPE is required when there is a potential for exposure to hazardous materials, such as biohazards, and proper PPEs and laboratory attire help minimize potential for skin exposure. And therefore, PPEs are appropriate in the laboratory work area, but they should not be worn outside of the work area. So let's talk about some of the PPEs that we see in the laboratory. So lab coats or exposed or disposable gowns. You should always wear a clean, buttoned, zipped, or snapped lab coat or disposable gown open to the back when working with hazardous materials. And the reason for that is that the lab coat or the disposable gown can do the following. It can act as a removable barrier between you and spills, splashes, infectious substances, and infectious substances. It can help delay the transfer of hazardous material to your clothes and skin. It can protect your clothes from possible contamination. It can prevent the spread of contamination outside the lab, provided that your PPEs, that your gowns aren't worn outside the lab. And each supervisor is responsible for ensuring that his or her workers, employees, students, and if applicable visitors, use the appropriate lab coat while they're working in there. It's really important that lab coats, it's not one size fits all, not one type is appropriate for every situation within the laboratory. So lab coats are available in a variety of materials, and those materials provide varying degrees of protection. So you've got splash resistant coats, you've got static free coats, you've got chemical resistant coats, you've got flame resistant coats. So you want to make sure that you're choosing the one that's appropriate for what you're going to be doing. If you are working in pathology, if you're working in pathology or you're working in the morgue, then you want to make sure that you, because you're going to be dealing with formalin and those types of things, that you have a chemical resistant gown. So you want to make sure that the selection is appropriate for that, for the area of the lab in which you're working. What are some recommendations about the selection of that? Well, first of all, the length. Lab coats should be at least knee length or longer for the most effective coverage. The lab coat should have a wristband, a fitted wristband or cuff, and that reduces the potential for splashes up the arm as well as for fire hazards. It should have a top button, and that top button should be closed, and that is to provide the most effective protection. And then it should be fire resistant. So lab coats made of a polyester cotton blend with no less than 35% cotton are acceptable in labs where no open flames are present. But if you use like open Bunsen burners, which I know most labs have migrated away from now, we all use like in the little desktop incinerators, loop incinerators and such. But if you're still using alcohol burners, then your lab coat must be made of 100% cotton or a flame resistant material. And the reason for that is that with the other lab coats that aren't flame resistant, especially those that are polyester synthetic fabrics, that synthetic fabric can burn, it can melt, it can shrink, and it can stick to the skin. So it's really important that if you're working around open flames, that you don't have a synthetic lab coat. You do want to wear a lab coat when the hazard assessment within the laboratory determines that hazards are likely. And a good rule of thumb is to wear a lab coat when working in the lab. You want to make sure, so some things to remember: wear a lab coat of appropriate size, and it needs to fit you properly. Choose a lab coat based on the type of work that you're going to be doing. We talked about that. Keep your lab coats completely buttoned up. Snap closures are preferred, and the reason for that is if you need to get the lab coat off rapidly, you can pop the snaps. Whereas if it's a zipper or it's buttoned, it's going to take a longer amount of time to do it. You shouldn't wear disposable lab coats for more than one shift, for more than 8 hours. And it should be changed if it becomes visibly contaminated. You never want to roll the sleeves up on the lab coat, either for comfort or ventilation, because then you lose the protective value of having those sleeves covering your forearms. And you don't ever wear your lab coat outside of the lab work area. That's important too, because then you could be transferring microorganisms to other areas of the laboratory, as well as other areas outside of the laboratory. Gloves or hand protection. So hand protection is needed if there's a potential for skin absorption of harmful substances, chemicals, or thermal burns, electrical dangers, bruises, cuts, punctures, fractures, and amputations. So the type of PPE required may include gloves, finger guards, arm coverings, elbow length gloves. So what are some of the things to know about gloves? Well, one type of glove does not work for all types of hazards. So latex gloves are suitable for wear while working with some of the biological hazards and infectious materials, but latex can cause allergy problems in some individuals. So as an alternative, a lot of healthcare workers now will wear nitrile gloves. They're 3 times more puncture resistant, and they provide superior resistance to many kinds of chemicals. So it is a good alternative, especially if you're working with the low and intermediate level disinfectants in the laboratory. Leather gloves are often found in construction areas, but also in areas where people are working with a lot of glass, because they're puncture resistant. Neoprene gloves are synthetic, and they're highly liquid proof and chemical resistant, and they're great for specialized chemicals, especially when you're working with acids and solvents. And then heat-resistant gloves can be found in areas using autoclaves and other heat or steam cleaning machines. But for the person who is working in, who runs the autoclave in your microbiology department, they should have heat-resistant gloves for managing the materials that are coming out of the autoclave. Eye and face protection. If you're exposed to eye or face hazards, then it's important that you wear the appropriate protective gear. So goggles are primary protectors intended to shield the eyes against liquid splashes. Safety glasses are also primary protectors, and they're usually we see them, but the problem with the goggles and the safety glasses are sometimes they get fogged up, and so people have a tendency to fiddle with them a lot, which is a problem. So you really should have glasses that fit properly. Safety glasses are sturdier, so they're better. Another alternative to the use of goggles and safety glasses is the use of face shields, and they're secondary protectors. And what they do is they protect the entire face. So when paired with a respirator or mask, then they can provide an adequate level of protection. Respiratory protection, and you can see here I've shown the two primary types of respirators that we see. We're all familiar, and this is kind of a wonky looking one, but we're all familiar with N95 disposable face masks. And during COVID, some hospitals, although it was less common in the Caribbean, some hospitals actually reverted to the use of half-face respirators for respiratory protection. It has the same efficiency, the 95 to 99% that you can see in the N95 and the N99 respirator masks, disposables, but it has the added value of being able to put filters on that benefit when you're dealing with chemicals. So if you have somebody who's working around formalin, then they should be wearing this type of mask to help protect themselves. So some general principles on the use of it. Damaged reusable PPEs should be removed and replaced as soon as possible. You should never wear your PPEs outside of the isolation room, the laboratory area, you know, wherever it is that you are wearing it to protect yourself. When you leave that area, then you need to make sure that you remove it after completing the process or when you leave that area. And that protects not just you, but also your coworkers. And then after removal of PPEs, hand hygiene should always be performed. And as I stated earlier, gloves do not replace the need for hand hygiene. So I talked a little bit about the appropriate use, but some things that are important to keep in mind is that PPEs only work if the healthcare workers have access to them. So you have to have an adequate supply of PPEs available, and you have to make sure that the healthcare workers are trained in the appropriate donning and doffing and use of those PPEs. The use of visual reminders as part of a multimodal strategy helps to reinforce the training that healthcare workers receive in selecting and donning and doffing their PPEs. So it's good to have visuals around. And then it's important that healthcare workers are trained and understand that those PPEs act as a barrier between them and the infectious substance. It helps delay the transfer. I went through all these before, and it protects their clothing. But it relies on the healthcare worker using the PPEs as they're designed and in using them properly as they're trained. So there should be some type of monitoring going on in the process of using PPEs to ensure that your healthcare workers are using them properly. And then, as I said, your PPE should remain in the area they're being used. They should not be worn outside of that area, no matter where you're going. And that's really important because too often people will wear their PPEs outside of that specific area where they're working, and that puts other persons at risk. Okay. So when you talk about risk evaluations and the use of PPEs, so the first thing you want to do is this is a patient care, but it also applies in the laboratory setting as well. So you have to look at the type of interaction or the type of process that you're going to be conducting. And then you have to think about the mode of transmission of diseases that are possible in relation to that process. So if you're doing chemistries, and so you're setting up the samples to put in the machine, then your interaction is going to be those that are related to the handling and management of blood, which is a potentially infectious material. So in order to prevent exposure to that blood, then you're going to be looking at standard precautions. You know all about them. So you're going to be wearing, you might be wearing a gown. You'll be wearing gloves in the handling when you're opening the tubes, when you're and you need to reevaluate what you need. So this could easily be altered, and you could say, I'm going to be setting up a respiratory specimen. So then the mode of transmission that I'm concerned with is droplet and airborne, and the amount of body fluid that will be generated, it could be sufficient for me to inhale. So at that point, I'm going to be looking at standard precautions because everybody does. But if I'm dealing with somebody who has a respiratory disease, such as possibly tuberculosis or influenza, then I'm going to be looking at the precautions that I need, the PPEs that I need. And so the PPE for airborne would be an N95 respirator. So this is the type of risk evaluation that you want to conduct every time. And with experience, it becomes second nature. But to start with, you do need to mentally go through this each time and say, okay, what do I need to have for personal protective equipment in order to accurately and adequately protect myself. So that covers those standard precautions. And so now I'm going to talk about laboratory infection control. So laboratory infection control practices have traditionally been included as part of a lab safety program for years. And so what we're looking at is in doing this is we know the principal routes of laboratory transmission. They did surveys in the US between 78 and 86, and there were reported annual incidences of 3 to 3.5 infections per 1,000 employees per year. The present incidence of laboratory acquired infections, which are a healthcare associated infection in the laboratory, is unknown. However, the WHO did some work, and Wilson and Reller estimated that the current rate in the US might be approximately 1 to 5 infections per 1,000 employees per year. So, and what's even more critical to know is clinical diagnostic laboratories accounted for 45% of all laboratory acquired infections. So laboratory workers, and especially those in micro, are at greater risk of being infected than the general population. And so the causative source procedure, but a lot of times that there isn't documentation for the causative source, the procedure that was being conducted at the time that caused the transmission, or actually the breach in technique, couldn't be identified. In 2008, the Centers for Disease Control convened a blue ribbon panel to review laboratory biosafety and diagnostic laboratories, and the Clinical and Laboratory Standards Institute, CLSI, has published guidelines on the protection of laboratory workers from for occupationally acquired infections. So there are several resources available for infection control. So I spoke earlier about the hierarchy of controls, and with respect to infection control in the laboratory, there are specific administrative controls that have to be considered. So, and those we're going to talk about right now. But this is just to let you know that while a lot of times we apply this hierarchy of controls in, we look at it and we report it and use it in patient care areas, but this applies to all areas of the hospital. So it's not just for doctors and nurses, it's for people in every area. So this hierarchy of controls could be applied with different elements, that the same, like elimination, substitution, all of these, but specifically aligned for laboratory or for a maintenance department or a bioengineering department. So it could be applied in all those settings. So what are the administrative elements of a safe clinical laboratory? So personal protective equipment, programs and procedures. And as I stated earlier, you have to have adequate supplies of those proper PPEs, or it's pointless to have a PPE program and procedures on which PPE should be used, in which situations, who should be donning and doffing, when should they be donning and doffing. There should be a respiratory protection program, biosafety, exposure control, and chemical hygiene plans that include procedures to address accidental spills of infectious organisms or release of infectious microorganisms into the laboratory environment. There is need for a comprehensive plan for the management and disposal of infectious waste, including blood and blood products, medical surveillance for infections that may result from exposure to agents encountered in performance of routine duties, or when early diagnosis reduces the risk of serious consequences of infection. It's important that the laboratory has a safety manual that is acknowledged and understood by employees and it has to include the occupational risks and consequences of infections to which they might be exposed. So if you have somebody who's handling large volumes of blood, then they need to understand the risks and consequences of exposure to hepatitis B, to hepatitis C. In the microbiology setting, you have to have the manual and the occupational risks of exposure to tuberculosis, to salmonella, to shigella. So you need to be, they need to be part of, that needs to be part of what's going on in all of the safety program and the infection control within the laboratory setting. The promotion of safety awareness through training programs and required adherence to safety procedures. I spoke earlier about the need to have a monitoring program going on. So you would be doing, in the healthcare arena, on the floors, they may be doing surveillance for hospital-acquired infections, but they also do monitoring of adherence to hand hygiene and other elements of standard precautions. And this is the same type of situation that the required adherence should be monitored within the laboratory. And then consistent observance by all workers of proven safety and microbiological practices. So, and then lastly, but certainly not least, is documentation and reporting of all occupational injuries, illnesses, and incidents of potential exposures. And the reason for that is because the management portion of the laboratory needs to be able to go back and see where are your exposure prone processes and what elements are failing. So they may have to reapply a new administrative control, relook at the way the work's done in order to make it a safer clinical setting. So within laboratories, and you all are familiar with this, in general, the strategy for minimizing occupational exposure of laboratory workers to infectious agents is based on microorganism containment. And so that we're gonna talk about these components. That includes your facility design, the safety equipment, your standard microbiological practices, and administrative controls that are applied. Microorganisms, and remember I said at the beginning of the laboratory component of it, that clinical laboratories account for 45% of all laboratory acquired infections, and it's predominantly microbiology that is at the highest risk area. But anyway, primary risk criteria are used to define the 4 ascending levels of containment and biosafety levels, BSLs, 1 through 4. So risk group 1 is no or low individual or community risk, and that microorganism is unlikely to cause human or animal disease. Risk group 2, moderate individual risk and low community risk. Biosafety group, risk group 3 is high individual risk and low community risk. And risk group 4 is high individual and community risk. And so when you look at these, then you can start to see, so in risk group 1, then the basic biosafety level is going to be level 1. And work can be done on the open bench, and it's just good microbiological techniques. When you get into basic biosafety level 2 for the risk group 2, this is the predominant type of laboratory that we see in our Caribbean health facilities, outside of those that perform research or in the big tertiary care facilities. So it's an open bench. They might have, and they would have a biological safety cabinet for potential aerosols. There's PPEs, there's biohazard signs. So you can see this type of thing. And then when you get to level 3, and today I'm not going to discuss level 3 and level 4, I'm going to talk about I'm going to focus primarily on biosafety level 2. But when you get to level 3, there is a need for special clothing, controlled access, directional airflow. So that's how that risk group applies with the biosafety level that's necessary within the laboratory for a safe lab environment. So when you look when you look at this table, it summarizes the facility requirements at the 4 biosafety levels. And you have to keep in mind that the biosafety level assigned for this specific work or task to be done is driven by a professional judgment that's based on a risk assessment rather than an automatic assignment of a biosafety level. So you need to make sure that this isn't a locked-in type of situation where, and as an example, in a biosafety level 2 facility, some tasks may necessitate biosafety level 3 because the procedure that they're doing might produce high concentrations of aerosols. So you might be in a biosafety level 2 with some biosafety level 3 processes going on that are going to require additional types of equipment. Oh, went too fast. So the primary risk assessment that's done in laboratories is the microbiological risk assessment. And microbiology risk assessment is the backbone of laboratory biosafety. So risk assessments should be completed by persons that are knowledgeable about the organisms that are being handled in the laboratory. So it should be somebody, it should be like the micro supervisor or somebody who has an idea of the history of the types of organisms that are being seen, the work that's being done, the procedures and the equipment that are going to be utilized, and the containment equipment and facilities that are available within the laboratory. And then the risk assessments should be reviewed routinely and revised when necessary. So factors to consider when conducting a risk assessment include these that are shown here, such as the pathogenicity of the agent and the infecting dose. So if you have, if you're managing high specimen counts with Shigella, obviously Shigella has a very low infecting dose. So these are the types of things you need to have somebody that's knowledgeable about the organisms that they're dealing with in there. And if you're infected, what's the potential outcome of that exposure? Is it likely to cause disease, or is it less likely to cause disease? You have to be, the person that's conducting the risk assessment needs to be familiar with the natural route of infection of the typical agents that are seen in the laboratory. If you deal with a high volume of Mycobacterium tuberculosis, obviously then you've got to be concerned with airborne for all of your respiratory specimens, and also specimens that are coming from the theater that may have a potential for tuberculosis, such as tuberculosis, osteomyelitis, and such. So you have to look at other routes of infections, and how do they result from laboratory manipulations? So if you are emulsifying some pathological specimen for culture, then you need to be concerned with how you're mixing it. Is there a potential for droplet transmission? Is there a potential for airborne release of airborne pathogens? So that type of thing. And then also, what happens in the laboratory? Do you have specific persons that work in your laboratory areas that are at higher risk? Somebody who's recovering from cancer, or somebody who has some type of immune irregularity or something like that. And then, like I said, what types of laboratory activities do you do in that laboratory area? Do you do sonication? Do you do aerosolization? Do you centrifuge? Genetic manipulations, those are not going to be seen in most of the level 2 laboratories, but you could see it in the level 3s in the few tertiary care facilities that we have within the Caribbean. And then for those infections that can happen, is there effective prophylaxis or therapeutic interventions? Because if it's not available locally, then that's going to up what happens, the natural route of the and potential outcomes for the exposure. So these are the components that are taken into account in the microbiology risk assessment. And this takes place not only in the microbiology lab, but also in the other areas of the laboratory, because everybody's managing specimens of some type or another. So you need to make sure that this risk assessment is done in all the different areas. So pathology may be a little different than the morgue. The morgue's going to be a little bit different than microbiology. Chemistry and hematology are going to be different than microbiology. So it should be done in all areas within the laboratory. And then in those situations where you're dealing with specimens that you don't have a lot of information about, then it's good practice to follow standard precautions routinely. And then also make sure that you are using at least biosafety level 2 practices and procedures for handling those specimens where there's limited information. So the code of practice is a list of the most essential laboratory practices and procedures that are basic to good microbiological technique. So diagnostic and healthcare laboratories should be at least a biosafety level 2 or above. And the guidelines presented here are comprehensive and detailed, and they're fundamental to labs of all biosafety levels. The guidelines for biosafety levels 3 and 4 are actually modifications of these that I'm going to present. And so since I'm not going to be discussing levels 3 or 4, I'm going to list the codes, but I'm going to focus on those that are associated with infection prevention and within that context, only up to biosafety level 2. So access to the laboratory. And some of these are going to seem so common sense to you. You're going to be like, why do we even have to put them down in writing? But obviously, only authorized persons should be allowed in the laboratory working areas in order to prevent inadvertent exposures to biological hazards. The laboratory doors should be kept closed during working hours to deter unauthorized entry, and it's prudent to keep the doors locked when the laboratory is closed. Children should not be authorized or allowed to enter the laboratory. And then where biological agents are handled, the hazard warning symbol must be displayed at the entrance of the rooms. And this is the biohazard label that we should be seeing. Personal protection, we talked about this earlier. But consistent with standard precautions, gowns or aprons should be used. Gloves worn when there's anticipation for potential with direct contact or anticipated accidental contact with potentially infectious material. But that being said, it's not mandatory that you wear gloves while handling plates, transferring colonies with use of loops or such. But it is mandatory that you perform hand hygiene after completing that work, and especially prior to touching your face or mucous membranes. For example, when you're going on tea break or to the restroom. PPE should never be worn outside the laboratory, and this includes the lab coats that are worn while working at the bench. Eating, drinking, applying cosmetics, and handling contact lenses pose a significant risk of disease transmission and should never be allowed in the work area. And tea and lunch breaks should always be taken in a separate area outside of the work area. And food and drink should never be stored in lab refrigerators, and they should be stored in a separate refrigerator in the tea room. Mouth pipetting is strictly prohibited. And in fact, nothing should be done by mouth in the lab work area. And this includes tasks such as licking labels. So any labels that are used in the laboratory should be self-adhesive. And because of the risk of disease transmission by a droplet spread or airborne spread from aerosols, procedure should be done in a manner which minimizes the formation of droplets or aerosols. We talked about safe injection practices, and the use of needles and syringes should be minimized if at all possible. And if you do have to use them, the use of safety needles is recommended because they protect healthcare workers from needle stick injuries. There should be a written policy and procedure for the management of blood spills, and as well as exposure to blood and other potentially infectious material. Excuse me. It should be every healthcare, every lab worker should be familiar with the policy. And then and they should be posted for easy reference so that in the event of an inadvertent exposure, everybody knows just what to do. All accidents and exposures to potentially infectious materials should be reported to the supervisor immediately, but it should not impede immediate medical attention if necessary. And then another component is the contaminated liquids. So if you are on a sanitary sewer system, so in other words, if you're connected to a sewer system, then contaminated liquids should be disinfected prior to disposal. Excuse me. If you are on a septic system, if the laboratory in which you work has a septic system, a septic tank, then decontamination or liquids can affect the septic system, and careful consideration has to be taken as to which of those are applied to prevent killing the microbes in the septic system. Laboratory working areas, the importance of cleaning the work area when handling potentially infectious material, I can't stress it enough. Because the problem is the ease with which we can transfer those microbes from our work environment to our mucous membranes with our hands inadvertently is high. It's important to also prevent infestation with mosquitoes, flies, and other arthropods. So if you have laboratories with windows, then those windows should have screens to prevent the influx of those types of things. And then contaminated materials, specimens, and cultures should be decontaminated before disposal. And then biosafety management. So biosafety management is the same as exposure control. So this speaks to staff being familiar with exposure management policies and procedures, as well as identifying someone with responsibility for overseeing the process. But that includes ensuring that the staff are trained and updated regularly on exposure management. This would typically take place as part of an annual review program. And in the event that staff are exposed, the need for medical evaluation as well as follow-up is critical, even in situations where there's no screening tests available, because in some instances you can provide preventive treatment. In others, there's medical management, but the staff member should be monitored in any event to make sure that if they do contract a laboratory-acquired infection, that they receive appropriate medical management and treatment. So I'm going to briefly review this, the components of this that facilitate infection prevention. Obviously, ample space for the safe conduct of the work, but not only that, there has to be ample space so that you can clean the place. So your surfaces have to be impervious to liquids, resistant to chemicals and disinfectants. They have to be easy to clean. Your floors need to be non-slip. Your bench tops have to be impervious to water and resistant to disinfectants, acids, alkalides, or organic solvents, and moderate heat. Obviously, you should have adequate illumination. Your lab furniture has to be sturdy, has to be able to be cleaned, and if necessary, disinfected. And there has to be sufficient space, both between and under the benches, cabinets, and equipment, so that it is accessible for cleaning. And then there needs to be storage, because you want to make sure that you don't have a cluttered environment that doesn't allow you to properly clean it and with respect to the bench tops, disinfect them daily. So that's really important. Facilities for eating and drinking that are outside the working area. And hand washing basins with running water should be available in each laboratory working area or room. And then there should be an autoclave or other means of decontamination in proximity to the laboratory for labs that are BSL level 2 and above. Laboratory equipment. It is important that pipetting aids are available to avoid mouth pipetting. There is a need for biosafety cabinets, and these biosafety cabinets should be used whenever infectious material is handled. Such material may be centrifuged in an open lab if you have sealed centrifuge safety cups. And they are loaded and unloaded in the biological safety cabinet. You should use a biological safety cabinet if there's an increased risk of airborne infection. And as I stated earlier, if you process large numbers of specimens for tuberculosis, so you have a large number of tuberculosis patients in your laboratory practice, then you should have a biological safety cabinet for managing all respiratory specimens. Procedures with a high potential for producing aerosol are used. This includes typically centrifugation and grinding, blending, any vigorous shaking or mixing, sonic disruption, opening of containers of infectious material. So those are the times when you should be using biological safety cabinets, biosafety cabinets. The laboratory should have plastic disposable transfer loops, or alternatively, electric transfer loops. Incinerators can be used inside the biosafety cabinet to reduce aerosol production. They should have screw cap tubes and bottles, plastic disposable Pasteur pipettes whenever available. And the reason for that is to avoid glass, which is a risk for sharps injuries. Okay. And then with respect to the autoclaves in the biological safety cabinets, autoclaves and BSCs should be validated with appropriate methods before they're put into use. And the recertification should take place at regular intervals as recommended by the manufacturer. So it's not a one and done. So you need to make sure that your autoclaves and your biological safety cabinets are being validated on a regular basis to ensure that they're working appropriately and properly. Continuing in-service education and training is essential, and training should include inhalation risks, and that is aerosol production when using loops, streaking auger plates, pipetting, making smears, opening cultures, taking blood serum specimens, etc. And then ingestion risks, there should be training about that when handling specimens, smears, and cultures. There's risks of percutaneous exposures when using needles and syringes, handling of blood and other potentially infectious material, including pathological materials, and decontamination and disposal of infectious material. So these are the types of topics that should be covered in an in-service training program for the laboratory. Waste management. We talked a little bit earlier about, we have a typo in here. We talked about this a little earlier when I talked about waste segregation, and I talked about the general household waste, which is the non-contaminated, non-infectious. Then that includes office waste, papers and items that aren't used in the performance of laboratory procedures. Your contaminated infectious sharps include your hypodermic needles, your scalpels, knives, any broken glass that may be. And that's why with some of the pipettes and the Pasteur and the Pasteurs, then you need to make sure. That's why it's important to have plastic whenever possible to prevent the sharps injuries from the broken glass. We talked about needles not being recapped, clipped, bent, or removed from disposable syringes. And then your containers for your sharps should be they should be puncture proof and not filled more than 3/4 full. And then your contaminated material, you have 3 types of contaminated material. You have contaminated material for decontamination by autoclaving, and thereafter washing and reuse or recycling. And this could be something like the glass cups and stuff that are used in the lab for mixing solutions or whatever. And then the one note is that in this situation in the laboratory, this is the one area where they don't recommend pre-cleaning. So when we talked about standard precautions and cleaning, disinfection, and sterilization, I talked about cleaning as being the first step. In the laboratory, because of high bioloads, they recommend autoclaving or something first, and then cleaning after the biological pathogen has been inactivated. You have contaminated material for autoclaving, followed by disposal, and so this material should be placed in leak-proof containers, for example, autoclavable color-coded plastic bags. And then those can be placed, once they've been autoclaved, they can be placed in transfer containers to be transported to an incinerator. And the last type of material is that is contaminated material, and it is sent directly for incineration. So there should be a waste management program that has appropriate separation of the waste according to the type of waste and the type of management of that waste. So I'm going to go over this briefly. This is a little bit in more detail though than what I did in the first part under standard precautions. We're going to talk about cleaning, disinfection, and sterilization here. So back to the basics. What exactly is cleaning? Cleaning is the first and most essential step before any process of disinfection or sterilization can be carried out. And again, with the caveat that in the laboratory, it's backwards to this. They don't recommend cleaning prior to disinfection or inactivation of the pathological agents. But cleaning basically is the removal of visible soil, organic and inorganic material. It's usually manual. It's accomplished either manually or mechanically using some type of washer sterilizer. And thorough cleaning is essential before high-level disinfection and sterilization. And the reason for that is that the reason that they say that you have to do that, at least with those patient care equipment, is because the organic material, the inorganic and the organic material that remains on the surface can interfere with the process of disinfection and sterilization. Oh. Sorry, I forgot to change the slide. There, okay. So the general principles: physical cleaning reduces the bioburden. We talked about that. And I noted that this bioburden, or this organic and inorganic material, protects those organisms from contact with the disinfectants, with the steam or the other chemical, and then it renders the process ineffective or less effective. But you should always follow manufacturer recommendations when cleaning. And some chemicals used for reprocessing devices are inactivated in the presence of organic material. So it's really important that whenever agents are being used in the laboratory, that you have appropriate counsel on which to use in which situation. So infection control should be able to give you guidance on the selection of not only cleaning agents, but also disinfectants. When you are cleaning, three or four of these can become very important components. So the first one is the mechanical energy, the friction that actually removes the inorganic and the organic material. The chemical action, the soap or the detergent, the chemical energy that's being used. And then some chemicals require a certain temperature range and application for a certain contact time. So it's those are all critical. And then the key in the middle here with the water is that hard water and soft water have different effects on cleaning. And so it's important to know what kind of water you have and how it impacts the selection of the agents that you're using. So when you talk about cleaning, there is first of all a chemical action, and when you talk about the selection of that agent to use, you have to look at what type of organic and inorganic material you're having to clean off of the surface of whatever you're cleaning. And so you have to look at each of these different components to see what is going to be most effective. So when you talk about saponification, when you talk about fat emulsion, this is the process where fats are suspended in water. The saponification, the surfaction is the release of the superficial tension in order to permit greater penetration. The dispersion or deflocculation, this is breaking dirt aggregates into smaller particles. Suspension is the process of maintaining insoluble particles suspended in water. And water softening is the removal of calcium and magnesium ions. And so these are some of the components to keep in mind. And unlike hard water, softened water will not form insoluble scale, and it doesn't precipitate in pipes. So it's important or interfere with cleaners such as soaps. So if you have scale forming on your glassware or such, then you know that means that you have hard water, and that could impact what's happening with your chemicals. A mild alkaline detergent is preferred for manual cleaning, and mild alkaline detergents have a pH range of 8 to 10.8. They're more efficient cleaning agents for surgical instruments, so metal instruments, than neutral pHs, but you have to, as I stated before, work with infection control, work with your chemical suppliers to pick what is going to be best for you within the health facility. The use of enzymes, cleaning agents sometimes contain enzymes, and this helps to break down proteinaceous material. They're not disinfectants, though. They only remove the protein from the surfaces. And when you're using enzymes, you can't use rubber or nitrile gloves. So that's an important component to keep in mind. And then when we talk about, so we've gone from cleaning, now we're going to talk briefly about disinfection. And disinfection is the physical or chemical process that eliminates vegetative microorganisms. And then there are different levels of disinfection. So you can see that there is low-level disinfection, and it covers enveloped viruses, it covers gram-positive, gram-negative bacteria, and fungi. And then intermediate level includes those, but also we'll pick up then the non-enveloped viruses and the mycobacteria. And then your high-level disinfectants will hit a small portion of bacterial spores, but for the most part, relatively similar to what you get with intermediate level. And then obviously sterilization covers bacterial spores as well. So when you look at disinfection, factors that affect it is the quantity and location of the microorganisms. So if there is a high bioload, then the amount of time that a disinfectant needs to act is increased. And that's why the cleaning is so important. You have to look at the resistance of microorganisms to chemical agents. And this refers primarily to the spectrum of action that we saw in this slide here. So that's what that's referring to there more than anything. The presence of extracellular material or biofilms. Biofilms are very, very difficult to penetrate, and so disinfection is rarely effective against those items that have biofilms forming in them, particularly if there are interior lumens. So there are two basic disinfection methods, and disinfection is truly one of the oldest procedures in the hospital environment. And it was originally used to eliminate microorganisms from the environment and to sanitize hands. So the two disinfection methods include physical through heat and different types of radiation methods, and chemical through a variety of antimicrobial chemicals. And the chemical is the more commonly seen disinfection method in the healthcare setting. So, but within the physical methods, pasteurization was a method originally used by Louis Pasteur. It's used to carry out actually high-level disinfection by bringing water to 77 degrees for approximately 30 minutes, but it doesn't do spores. But when you talk about the use of physical methods, it's not uncommon. Some of the hospitals now are starting to get water disinfector machines, and so those will actually take you through, and they'll clean and disinfect with a minimum amount of chemicals. As I stated, the chemical method, the liquid chemical method, is the most frequently utilized method in hospital systems, and multiple germicidal agents exist in liquid form. The problem is that this liquid method requires very many controls during its execution. Since it's a method that's carried out for the most part manually, all stages of the protocol recommended by the manufacturer and validated have to be closely followed. So you really need to have a step-by-step standard operating procedure that is followed every single time. And deficiencies in the disinfection process can result in serious infection or inflammatory complications if they come in contact with the chemical agents remaining on the articles that were chemically disinfected. And so the principal disinfectants that are used in hospital area are orthothaldehyde, glutaraldehyde, which is more frequently now being replaced with the orthothaldehydes, hydrogen peroxide, peracetic acid, phenols, and quaternary ammonias. And it's important to note that that not all disinfectants are available in all countries. So independent of the product used, you have to monitor the critical parameters of the process. So you have to make sure that the concentration of the disinfecting agent is correct, that the temperature is correct, and that the exposure time or the contact time is correct. So that means the temperature needs to be measured, the exposure time needs to be timed, it needs to be put on timer. And there are strips that can be used with liquid chemical methods that make sure that the concentration of the disinfectant is appropriate and it's not under or over diluted. But another important point is that it's important to check the expiry dates on the solutions to make sure that you're not using outdated chemicals. And when you talk about the concentration of these, the dilution can change over time, because when you pre-clean something and then put it in the disinfecting agent, there's carryover water. So over time, you could have a weakening of the concentration in your disinfection. So, and then for exposure, each disinfection method and agent has a specific amount of time that's necessary. So you have to follow it, because not all the products are the same. They may have different exposure times. So I talked about the expiry date. That's important. You want to make sure that whatever you're using is compatible with the disinfecting agent that you've chosen. One key critical point is it's important that you have proper forced ventilation. wherever you're doing this disinfection, because some of these agents can be toxic, and you can have reactions to them. And you don't use the same sink for washing and rinsing instruments. They have to be separate. And you don't want to perform high level disinfection in the actual work area. It should be in a separate area. Sodium hypochlorite, chlorine is a fast-acting oxidant, and it's a broad-spectrum chemical germicide. It's widely available as bleach, which is an aqueous solution of sodium hypochlorite. When used as a general all-purpose lab disinfectant, bleach should have a concentration of 1 gram per liter available chlorine, and a stronger solution, 5 grams per liter available chlorine, is recommended for dealing with biohazardous spills, such as blood spills. Sodium hypochlorite as household or domestic bleach generally contains 5 grams per liter available chlorine, and so should be diluted 1 to 50, or the household bleach doesn't contain 5 grams, it contains 50 grams. Per liter available chlorine, so should be diluted 1 to 50 or 1 to 10 to obtain the final concentrations of 1 gram per liter and 5 grams per liter respectively. Bleach may be used as a general purpose disinfectant for soaking metal-free materials. Remember, it's highly corrosive to metal, so you shouldn't be using it on anything metal, not even using it to wipe down metal components. Bleach has to be stored in a well-ventilated area, and bleach must never, ever, ever be mixed with acids, because it will release chlorine gas, which can be highly toxic. And as a general rule, bleach shouldn't be mixed with other agents. And this is a pictorial that was developed by WHO that talks about how to do bleach. So if you're using household bleach, then you prepare your 0.5, which is your 1 in 1 in 10 is your 5 gram available chlorine. So it's 1 part 5% bleach, 9 parts water. That gives you 0.5, and then you can take 1 part of this bleach solution, dilute it with 4 parts of water, and that will give you your 0.1. But it's important that if you have people who do not have good reading skills preparing your bleach, that pictorials similar to this are important in showing them how to make the proper bleach solutions. Okay, we're going to talk quickly about sterilization. I know I'm almost to time here. Okay. So we know that sterilization refers to the operations that eliminate or kill all forms of living beings or contained in or on an object or substance. And so sterilization has traditionally been utilized for those items that are going to enter a sterile space or cavity. But sterilization process is designed to kill 10 to the 5th microorganisms. You remember this, we showed it earlier, and sterilization incorporates the elimination of bacterial spores as well. And alkalines and oxidating agents are effective against spores, but sterilization is the process that will kill all living organisms, including spores. So that's really important. And that's why sterilization, as opposed to high level or chemical sterilization, is a better option. And we're going to talk about these briefly. So most medical and surgical devices in healthcare facilities are made of materials that are heat stable, and therefore they can undergo heat, primarily steam sterilization. But what if you have heat sensitive devices that can't withstand steam sterilization? So in that instance, you can use chemical sterilants such as ethylene oxide gas, hydrogen peroxide gas, and ozone. But physical sterilization refers to the use of heat, either dry heat or steam, for sterilization. And then sterilization by immersion in liquid chemical methods can be carried out manually, but it is the last method of choice. And the reason is that it's difficult to control those processes, and there is a great possibility of recontamination during rinsing or drying, and it doesn't allow for any packaging or storing. So steam sterilization is the process that uses saturated steam under pressure as the sterilant, and it's the preferred method for sterilizing critical medical devices. And the removal of air is essential to ensure that this sterilization process, because sterilization can't occur in the presence of air. And this steam sterilization is the most common sterilization procedure. And the equipment that's used is, as you're aware, it's called an autoclave. And this is just an example of an autoclave. But here it talks about this. So this is a gravity displacement, a gravitational autoclave. And what's really important is that the critical factors that need to be monitored are these components. So you need to make sure that the temperature, that the humidity, that the time, the quality of the steam, and the pressure are all being monitored during this. And the more modern sterilizers actually will give you printouts for those parameters. So what are the advantages and disadvantages of moist heat or sterilization with steam? The advantages is it's considered the most economical, it's the most rapid, doesn't have any adverse effects because it doesn't leave residues. But the disadvantages, it's not suitable to apply to materials that are heat sensitive. And then this slide depicts the time and temperatures that are necessary if you're using gravitational versus a pre-vacuum. And you can see that with the same temperatures that the times are radically different. So with the gravitational, where you may have to sterilize exposure times of 15 to 30 minutes at 121 to 123 degrees Celsius, when you go to a pre-vacuum, the times are more significant with the higher temperatures. So we're 10 to 25 minutes in the gravitational, you can drop down to 3 to 4 minutes in the pre-vacuum. And then while flash sterilization is utilized in some instances, it's definitely not recommended. And again, it has to do with the control parameters. And the last area that I would like to cover briefly today is immunization of laboratory workers. And the Centers for Disease Control have done extensive work and produced guidelines on immunization, vaccinations and immunizations in healthcare workers. And so when they do that, they talk about the general vaccinations, and then there are some microbiology staff that are based on the risk assessment. So in general, all healthcare workers should be vaccinated against the vaccine preventable diseases such as measles, mumps, and rubella. And they also should be vaccinated with TB, tetanus, diphtheria, or Tdap, tetanus, diphtheria, acellular pertussis. Healthcare workers should be vaccinated against hepatitis B. They should receive annual influenza vaccines, and they should be vaccinated against polio. And polio, while we would have thought that this is a disease that's going away, as you might be aware, we have seen an increase in polio cases in the last year. There is an outbreak. And so it's important to make sure that our healthcare workers are vaccinated against polio if they have not been. For microbiology, people, it should be based on the risk assessment. If you are managing Neisseria meningitidis specimens in your institution, then those healthcare workers who may be at risk for it should consider meningococcal vaccines. And if you handle specimens with Salmonella typhi, then there should be consideration for typhoid vaccines as well. So, but these are the ones that everybody should be vaccinated against. And I know there's a lot of pushback against annual influenza vaccines, but actually, while it may not prevent you from getting influenza, it does prevent severe consequences or severe cases of influenza. And it also can prevent you from passing influenza on to those persons who are prone to poor outcomes, including cardiac patients and persons in intensive care and neonates. So anyway, with that, that is the last slide that I have. And I would open it up to questions, and I definitely have a typo there. So if anybody has any questions, I would open it up, Wendy, to questions now. Over.
Okay, thank you so much, Kathy. That was a lot. It was very in-depth. I really appreciated how you broke it down for us in the different sections. It was very, very interesting. I had prepared a few poll questions, but I'd prefer if persons from the group, if you have questions, that you ask them now. I will allow a couple minutes for that. If you'd prefer, if I give you the poll questions, it's just 4 of them if you like. Then you can let me know as well in the chat. But Kathy, thank you so much. It's a lot of information for us to go over, a lot of things for us, to refresh our minds, because most of the labs would have instituted quite a bit of these practices, but how well do we follow up on them? How well do we ensure that our plans are up to date, etc., is very, very important. Yes, so I'm seeing you're getting some kudos in the chat. Great presentation. And of course, can they have access to the slides?
Absolutely. I can send that to you as a PDF, and you're more than welcome to share it with them.
Most definitely, I will. And, we've been learning over the past couple of sessions about some of the emerging and re-emerging diseases. And you had to go mention one, polio being on the rise again. We had a discussion with syphilis, which is on the rise again, not to mention things like measles and, of course, the neglected parasites that we did in our last lecture. So, it's just grounds for us to be aware and ensure that we don't do things that would endanger ourselves in the lab. We also mentioned gloves and its use in the laboratory or no use in the laboratory. I think my first exposure with working in a lab where they didn't routinely use gloves was at Mount Sinai, and I was at first shocked, but then it actually made you much more cognizant of what you were doing. So touching your eyes, fixing your glasses was a no-no. You never did it, because when you didn't have gloves on, you didn't feel like you were protected. And I know sometimes we may have gloves on in the lab and we decide, oh, let me pull it off, do what I'm doing, and then put the glove back on. You can get micro tears in the gloves you've been wearing all day, right? So it's no gloves actually probably is a little bit more protective if you think of it from that perspective. So that's cause for debate. Let me say that, because there are persons who never work in a micro lab without their gloves on. So things to think about. Safety devices that can be used to help to prevent sharps injuries as well, especially if you're using, for example, manual blood culture methods or even automated methods. Having the puncture devices that are single use, you pop it on, you don't need to uncap or recap or any, I don't know why we recap any sharps, but people do. Those devices can actually help to prevent injury. So it's something to think about in a laboratory where you're actually doing quite a bit of blood cultures to help to prevent sharps injuries. What else did I want to mention? Oh, you mentioned also some of the things that persons should not do, like licking labels and mouth pipetting. It seems odd to us now, but there was a time in the not too distant past where these were things that were actively done and it was thought of as the norm. So we may make our faces up now, but There's a time when it was done. Thank God those times, those days are over. But it's very important that we're cognizant of what we're doing in the lab. And sometimes what may seem like the norm now, in the future, we'll hear that, okay, it's cause for concern. So, just to keep ourselves up to date on what's happening in the world of IPC and ensure that we keep and maintain our safety. All right. Nobody said that they wanted the poll questions. I guess they don't want an exam at this hour of the night. So with that, I will say thank you again, Kathy. It was lovely to have you. You will be back with us next week, Monday, guys, Monday, 6 o'clock Jamaica time. And we'll be looking at hospital-acquired infection surveillance. Now, I know there are a couple of people online who are ready and waiting for that. And I know, Kathy, you'll probably have a few questions next class. Okay. Oh, here we have a question. What are your thoughts on disposable lab coats versus laundered lab coats? That's a good one.
That is a good question. Actually, there's two sides to that. If you are in a facility that launders your lab coats, then I think that the woven lab coats are better. But if you are expected to launder your lab coats at home, then my thought would be that disposable lab coats are a better option. But you should have a new disposable, or rather than a lab coat, a disposable gown, because you could use like a water resistant, doesn't have to be waterproof, but a water resistant, like yellow isolation gown or something. And then you could put a new one on every day. So the important thing with the disposables is they're meant to be worn and then disposed of and not reused over and over and over and over, because as they wear, they will become less impervious. And so it could put you at higher risk. So if you have a facility that launders lab coats, then the cloth woven lab coats would be better, just because they would be a better fit. They would offer more protection. But if you're expected to launder your own, then my recommendation would be disposable gowns that close in the back.
Yeah. And that's a very good consideration. I mean, I've been to places where at times, because of the equipment and the small spaces that they have, the staff may not even be able to keep a coat on all day. They may wear scrubs instead of, but then sometimes they may wear those scrubs out of the lab, which is a no-no. So having a disposable coat over, and especially the lighter material ones, shouldn't generate much heat. So this is actually a good option in such a scenario. And, sometimes you may have a hospital or a facility where they do the laundering, but then you may not get your coat back. So you take it home and launder it yourself. So if you're going to do that, you have to make sure that you're not washing it with your other personal clothing items or items of clothing from other persons in your household. And just take general precautions to ensure there is no transfer of infection. How are you packaging it to take it home? Are you dropping it in your bag? Little things that would help to prevent the spread of infection. These are all good notes to reason over.
Absolutely.
Yeah. I'm not seeing any more questions. I'm seeing a couple of thank yous and great presentation. Of course, they want a copy. So we'll pass it on to you as soon as it's available. Thank you again, everyone, for being here, for sticking out for the whole evening. And see you back next week. Kathy, thank you.
Thank you, everyone. Good night.
Night.